emergency briefing that we've decided to call because the situation is now so desperate. And we're going to start hearing from Sir David King, who will now make a brief statement. Sir David.
Well, good morning. Delighted that you're able to make it at this time. First thing is to say that there is news, of course, of the Oxford vaccine passing the MHRA test process, which is very welcome, but we want to just point out this is not the magic bullet. We are in a very serious situation, as you will hear from Christina, some of the details, and we therefore will require proper action today, now, from government. Delayed and tentative decision-making will result in the deaths of tens of thousands more people. We could manage this outbreak if we act quickly. Let me pass you back to Alice.
Thank you very much, Sir David, for that introduction and the reasons for this being such a pressing decision that we all have to make. And we always start these briefings with the facts and figures and sharing those with the public so that we can all understand what we need to do, why we need to do it. So now Professor Christina Pargell is going to share those latest facts and figures. Over to you, Christina.
Okay, so I hope everyone can see my screen. So this is going to be quite short, and it's just laying out the current situation in England. So this is the number of people testing positive by the date that they had a test in England. And you can see since lockdown has finished, this has really been shooting up to over 40,000 a day before Christmas. This goes up to the 23rd of December. We know that fewer people had tests over Christmas, so we need to wait a few days to kind of see what's been happening since then. But just the enormous numbers reported yesterday, I think means that we're going to see this continue to go up over the next few days at least. This is the number of people in hospital in England with COVID-19 to the 29th of December. We are now several thousand patients more in hospital than we were at the April peak. It went up by over 1,000 in one day occupancy in between Monday and Tuesday this week. And the problem is that by the time we reach this peak here, cases were coming down. We are in a hard lockdown in wave one, and we're not now. We know that cases are carrying on going up. So this is only going to get worse. So this really is quite a critical situation for the NHS. Looking at number of deaths within 28 days of a positive COVID test reported per day in England. So if we looked at just the first wave up to the end of August, there are almost 37,000 people who died within 4 weeks of a positive test. So far in the second wave, we've had over 25,000, and the most recent week was over 3,000 deaths reported. And the people who reported last week or over the last week, they probably caught COVID at the beginning of December. And so the massive increases that we've seen in cases and hospitalizations are not reflected in these numbers. So we will see deaths continue to go up over the next few weeks at least. And that means that we will, at some point in January, exceed the number of people who died in the first wave. And so we really have to do everything we can to try and keep these, to try and stop this just escalating further and further. This is just showing some data that the Office of National Statistics released from their infection survey, looking at the growth of the new variant. And you can see how in the east of England, the southeast, the east of England, the southeast and London, it has rapidly come to dominate cases here. This is only going up to the 18th of December, and we really need to have the new data to see how and if it has spread in other regions. We know it is present everywhere. And if we look at new confirmed cases per 100,000 people in regions in England, you can see the impact in the east of England, London and the southeast have really been shooting up since the end of lockdown, but all the regions are going up. So it's not the case that other regions in England aren't going up. COVID is increasing its transmission everywhere. And this is unfortunately, but not surprisingly, reflected in hospital admissions You can see that London now has by far the highest admission rate of all the regions, but the east of England and the southeast also rapidly increasing. And if the new variant starts spreading in other regions, we should expect to see that follow there. Every region, apart from the northeast and the northwest, now have more people in hospital today than they did in the first wave. And just the tiers, this is just looking at all cases reported per week per 100,000 people by whether you're in tier 2, 3 or 4, and this is using the tiers allocated on the 26th of September. So yes, you can see that tier 4 has been shooting up. It's quadrupled since lockdown case rates in that tier. We don't yet know if tier 4 is enough to contain COVID in the context of the new variant. We should know by this week, whether the end of this week, whether it is slowing things down in London and the southeast, but we really, really needed to reduce cases. That's what we need to do. We can't just plateau. We're at this extremely high level. But it's also true that cases are going up in tier 2 and tier 3. Tier 2 cases have doubled since lockdown is finished, and tier 3 cases have gone up by 50%. It's not the case that we have it under control with the tiers. And so this kind of incremental approach just isn't going to work because it's just going to keep growing. And I'm just going to end back on this slide because I think this is the one that really highlights the kind of crisis that we're in. And one of the really key points here is that the impact of Christmas is still to come. We know that there was a lot of Christmas mixing, understandably, last week. That will hit, the impact of that will hit next week, and it will come on top of the situation that we're already in. So I think I'm just going to leave it there for now.
Thank you very much for that, Christina. And now we're going to hear a clinical perspective from Danielle Bryden, who's Vice Dean of the Faculty of Intensive Care Medicine. Danielle, over to you. Are you there, Danielle? Oh, we seem to have lost Danielle for a minute, so we'll come back to her. But I'd like to hand straight back to Sir David, because we are not just about presenting the facts and figures, but also about a possible plan for meeting this challenge. Sir David.
We have a 5-point strategy to put to government, which we suggest should be rolled out immediately. The first point is a nationwide lockdown with immediate effect. As you've seen from Christina's data, the spread in London has been really rapid. But of course, we know that the big spread is coming from the new variant of the virus, and this variant is present throughout the country. We need to get ahead of it spreading rapidly, and this is why we're calling for a nationwide lockdown with immediate effect. Schools will contribute to the increasing transmission rate, and we have a fairly complex policy on schools. Happy to face questions on that. Thirdly, there's got to be a clear strategy to mark the end point of the lockdown. We haven't yet had such a strategy, and we're saying, once again, the find, test, trace, isolate and support system, with the stress on isolate and support. All those who have the disease and all those who've been in contact with them are isolated and supported. For example, New York is putting people who are asked to isolate into hotels that are requisitioned for this purpose, where they are fed and supported with medication where necessary. So there's got to be a clear end point to the lockdown, and that is when we are isolating everyone who's going down daily with the disease. Meanwhile, we need an explicit strategy for the rollout of the vaccines. Very welcome as the Oxford vaccine is, we now need a clear statement on the rate of rollout, the availability through manufacture of the vaccines, and how the procedure will be conducted. We need to know, for example, whether the army is going to be brought in to support both this and the support and isolation strategy I've just mentioned. we must see further financing going into the public health organizations to enable them to carry all of these things out efficiently and quickly. We must also support and contribute to the rollout of the vaccine to low and middle income countries. This goes over to our whole policy around aid support for developing countries. And we must institute an effective COVID control at our borders. All of that needs to be put in place, and we need it to be shared with us openly, honestly, and transparently. We need to understand that we could see tens of thousands more people dying, as indicated by the SAGE modeling subgroup that estimate by the end of June, another 100,000 deaths due to COVID-19 across the country. And let me just stress my last point. It's not only the deaths, but it's long COVID and the impact that has on so many people across the country, literally hundreds of thousands. So let's ask the government to act now to prevent this catastrophe rolling out further. Thank you.
Thank you very much, Sir David. And we have Danielle Bryden back with us now. So for that clinical perspective, then I'd like to invite you, Danielle. Danielle is the Vice Dean of the Faculty of Intensive Care Medicine in the UK. And I'd like to invite you to speak about the clinical perspective now, Danielle.
Thank you, Alice. I mean, from the faculty's point of view, we know that infections have been rising rapidly, and presentations to intensive care have been significantly increasing in parts of the country like Wales and London. But that's on a background of sustained pressure to intensive care in many other parts of the country, the Northwest, Yorkshire, the Midlands. And we are concerned about the staff working in intensive care, and particularly their resilience, both mental and physical, because this has been a sustained pattern of activity that they have been working on since the beginning of March, really. And they're both trying to look after patients with COVID and keep the rest of the NHS running in terms of other services. So it is a significant pressure on intensive care services at the moment.
Thank you very much, Danielle. And finally, for the opening of this briefing, I'd like to invite Professor Deenan Pillay, who is a professor of virology, to speak a little on the vaccines. Deenan.
Thanks, Alice. Just to finish off our presentations, it clearly is great news, the MHRA approval of the Oxford AstraZeneca vaccine, and perhaps is the one shining light of the international pandemic planning that's been going on over the last 10 years, 5 to 10 years, to actually allow such a rapid response to the genetic characterization of the virus less than a year ago, or in fact, pretty much a year ago. So that's a welcome. Does the availability of this vaccine in any way render our call undertaken by Sir David for a national lockdown irrelevant? Can we be relaxed? Can we wait for the cavalry to come, as in Matt Hancock's words on Radio 4 this morning? Well, no, in fact, it's the opposite. I think the fact that the vaccine is coming makes it even more important that we limit as many infections as we can, and I'll outline very briefly why. COVID-19 has proved far more prone to mutations and variation than I think many of us thought back a year ago. And in fact, that's evidenced by the continual emergence of new variants, many hundreds of variants that exist around the world. And of course, there's the ability through genetic fingerprinting sequencing of viruses, particularly with strength in the UK, to identify this. And of course, one of those variants is now the variant that is spreading widely within the UK with what seems to be high transmissibility. One of the problems and worries with regard to vaccines is some of those mutations that are actually leading to this higher transmissibility sit in the bit of the virus which is also targeted by vaccines. And one of the concerns has been whether these mutations will in fact compromise the effect of vaccines. Indeed, we know that some of these mutations have been identified that compromise other immune therapies, such as monoclonal antibodies and also convalescent plasma. And although we know to date, we don't know that in fact these mutations and this particular variant is going to compromise the effect of vaccines. We wait for more data on that for the 2 vaccines that are currently licensed within the UK, the 3 globally with Moderna as well. One of the big concerns is that this variant doesn't stop just now, is that we will see continual evolution of this virus, more and more variants, particularly variants that build on the current variants that are highly transmissible. We should expect that. And of course, that will happen with ongoing transmission and replication. Without replication of the virus, without transmission, there is no evolution of the virus. And therefore, in order to maximize the effectiveness of the vaccines that are coming through, there's another reason we need to really lock down and reduce all transmissions within the UK as much as possible. And that's why our strategy, as outlined by Sir David, is also part of the component of maximizing the effectiveness of this vaccine and future vaccines coming on stream. Thank you very much.
Thank you very much, Dean. And now we'll go straight to our first question, which comes from Hugh Pym at the BBC. Hugh.
Thank you very much indeed. Can I ask just a couple of factual questions and then a broader one?
We've got quite a lot to get through, actually, Hugh.
Okay.
So if we could maybe 2 questions, but not 3.
All right. Well, I'll come back to the factual ones at the end. But based on Christina's numbers, a comment from Christina on, based on the case numbers we've seen in the last few days and this dramatic increase to about 50,000 and Christmas, whatever that might contribute, there must inevitably be a surge of hospital admissions in January, as you say. Can you give any sense of the scale based on what you know with the current numbers? And the second question would be, a nationwide lockdown is obviously a very big call. What does Independent Sage feel the exit strategy should be linked to the vaccines? In other words, if you were advising ministers, what criteria would you want to see with vaccination rollout to enable the beginning of the easing of a lockdown?
Thank you very much. So let's start with that first part of the question, which is about the scale of this potential surge at the moment. And I wonder, Anthony, if you've got a perspective on that, if I could bring you in. Professor Anthony Costello.
So I think in terms of the surge in cases going into hospital, I'll let Christina discuss that. But on the vaccine rollout, I don't think we would link the lockdown specifically to how vaccine rollout will take place. I mean, it's great news about this vaccine this morning, but at the moment we're doing 50,000 vaccines a day. And Matt Hancock says that we'll get up to 2 million per week very quickly, which is actually, that means that that's 6 times what we're doing at the moment. And if we're to give 2 doses to 22 million people, that's the number of people who are over 65, frontline workers, or with underlying conditions, that will take till June. And if we're going to reach herd immunity, it'll take till the end of the year. So let's get this in perspective. And, we need to know about the details. David King mentioned the army, but what about volunteers? What about retired doctors and nurses, logistics? How are we going to reach minority groups? Will we need a 3rd dose? And we didn't succeed on isolation, trace and isolation, when we could have used these people. So I'm rather worried that the ambition may be in advance of what we're actually capable of. And I know that President Biden in the United States is very worried about vaccine rollout there as well. So I think on the vaccine front, that politicians, the media, financial markets all seem to think that the arrival of a vaccine means that this pandemic is over. And it very much isn't. And that's what we're saying at the moment, particularly with the crisis facing our hospitals. But finally, I would just say that test, trace, and isolation is even more important now. It's not less important for the reasons that Deenan has said, that, you know, we're a one club golfer at the moment. We've only got lockdowns, and lockdowns are very damaging, as you know. But of all the mitigating mechanisms we have, trace and isolation is the most specific and therefore the least economically damaging. And we have to invest in that because we're going to face the real prospect of continuing outbreaks throughout this year.
Thank you, Anthony. Christina, I wonder if I could bring you in as well on that first part of Hugh's question, which was about the scale of the challenge.
I mean, I think all we can say for sure is that it's going to get a lot worse, because what we don't know is what people actually did at Christmas. So how many people followed the guidelines, how many people didn't, and I'm sure there will be some, especially people who'd already made plans that were, you know, they're then asked to change very late on by the government. So we just don't know. And I also don't know quite how many people would have left the southeast and potentially spread the new variant, you know, further in the north. So I think, unfortunately, we are flying a bit blind, especially because with testing and lags over Christmas period, we really right now, I just don't know where we are. I don't even know if tier 4 is working. So it makes me really worried, because you can see the pressure on hospitals is immense. And if it keeps going up by 1,000 a day in hospital, then we're really going to keep struggling.
Thank you, Christina. And now moving on to the second question from Hugh. So David, I wonder if you could elucidate a bit further on the exit strategy, which is incredibly important. Obviously, lockdown isn't the solution and neither is the vaccine. Something has to happen in between. Oh, you're muted, Sir David.
In a way, Anthony did answer that, and that's exactly what we are saying. Test, trace, isolate, and support is the classic way to deal with an epidemic. And we haven't yet got it managed in the first 10, 12 months of this operation. Now we must do it, taking our foot off the pedal, because there's a vaccine arriving by May, June this year at some level, but by the end of the year to give us some sort of herd immunity is just not, it's too slow. And as Deenan set out, we run the risk of further mutants emerging. We don't know what these current vaccines will do with the new mutant.
Thank you very much, Sir David. And Hugh, you did say that you had a third question, so I think we can squeeze that in if you'd like to ask that as well.
Thank you very much indeed, Alice. It's just a very brief factual point. Your call for nationwide lockdown is for all the administrations of the UK to do that. I presume that's what you mean by national. And secondly, the closure of schools, is that the closure of all schools with, you know, no end point set, if you like?
So David, and then Susan.
So just very, very quickly, we in the first part of your question, yes, we are saying we need this lockdown quickly to come in and deal with it. But I'm going to turn to Susan, if she's here, to answer the question about schools, which I think is the critical part of your question.
Thank you, Sir David. Professor Susan Mickey.
Thank you. So what we're calling for is to get schools safe for staff and children to return to as soon as possible. What the chaos of December, with more than 20% of children off school and lack of planned online teaching, showed us is that we need to have proper planning and proper investment to make schools safe. And we're suggesting closing down, well, not closing down schools because they must be open for some children, but offering online teaching for January in a planned way and using January to make schools safe. So getting extra space from unused buildings to allow 2-meter distancing, having support for improved ventilation in all schools, free masks and encouraging students to wear them, multiple sanitizer stations, and immediately providing digital access for all children, laptops, tablets, whatever's needed, as has been promised previously but not delivered. and to recruit retired teachers and others who can help provide excellent online teaching. So this would be real-time teaching of children. But for those children where there's not adequate space or for whatever other reason they can't be taught at home, they should be able to attend school along with vulnerable and key worker children who are already attending school in a lockdown situation. And to achieve this plan, we need an immediate government task force, which includes the teaching unions, local authorities, governing bodies, and parents, even children, to implement this plan. So actually have the government take a partnership approach to what is a really serious situation, because everybody wants children in school, but we can't afford an even worse situation than we saw in January, in December, which inevitably would be the case.
And you mean UK-wide effectively for all these measures, presumably? Yes.
I mean, there's a discussion about some of the islands of Scotland, etc. But because, as has been outlined, the increase in transmission and the transmission of the new variant is happening across the country. The only way of dealing with this crisis will be to do this at a national level.
Thank you very much. Christina, you wanted to add something there.
Yeah, just to say, so Northern Ireland, Wales and Scotland are already in, versions of national lockdown, and England is the only nation in the UK that still has a kind of a regional system. So we're kind of concentrated on England for that reason, and because if England doesn't get it under control, it affects all the devolved nations. But yes, there should be a UK-wide strategy, and definitely for border control, it has to be UK and Ireland, Republic of Ireland strategy as well, because that's the two geographical islands.
Thank you very much, Christina, and thank you, Hugh, for your questions.
Thank you.
Moving on now to Paul Brand from ITV. Paul, are you there?
I am here, yeah. Hopefully you can hear me.
We can.
Just two quick questions on schools, please. Firstly, how much of the spread do you believe is being generated by schools continuing to remain open? And without the complete and sustained closure of schools, do you think the Tier 4 measures are enough to get this virus under control?
Thank you very much. Who would like to start with that about transmission within schools? Christina.
So I might let Deenan talk about whether the new variant is particularly more infectious among children than the old variant. But we know that if it is more transmissible in general, then it will affect children as well as other people. And we know certainly in the Southeast that schools were particularly badly affected in December, where significant proportions of children were off or either with COVID or isolating, and the same for teachers. Back in September, SAGE estimated that schools at that point would contribute between about 0.2 to 0.5 to R. And even if that is still the case and it hasn't gone up with the new variant, that is still too much while the new variant is running pretty much rampant. So I think that is why we're thinking that right now we just have to not have children go back to school, because basically they're buildings full of people mixing, and that's a problem. In terms of whether Tier 4 is enough, so far there haven't been any signs that things are slowing down. And I was looking at the King's College Symptom Tracker app as just one other way, and things are still going up there in the southeast and London. We should see that by the end of the week. It should have at least slowed down growth. If it doesn't, then I really don't know what to say, but it should be slowing it down. But we have to reverse it. We have to get cases to go down. And if Tier 4 is not enough, then we have to do more things. And one of those things is the isolation strategy that Anthony was highlighting earlier. Like, we have to isolate people and support people to isolate.
Thank you, Christina. Deenan.
Yeah, thanks. Just briefly on this issue of children and transmissibility. It does look to me as if there is increased rates of transmissibility amongst young children. Certainly the ONS data has shown an increase in the sort of youngest age group as opposed to the secondary school age where we know that infections have increased. There's a bit of dispute in the between PHE and others within SAGE and elsewhere about this issue, but my sense is that this is one of the areas where the new variant is making a qualitative difference to the pandemic. It's not just increasing transmissibility, but it's actually increasing the age range, the younger age range. And of course, with that comes other transmission dynamics of young kids being able to then transmit to teachers and parents. So I do think we need to, whilst there is some dispute in the scientific press and debates, I do think we should be err on the side of caution in this respect.
Thank you very much, Dean. And does anybody else want to comment on those questions before I move on? Thank you very much for those questions, Paul. Moving on then to Dr. Sonia Adesara, who's an A&E doctor in a London hospital. Sonia. Is Sonia with us? Yes. Hello.
Hi,
Hello.
just to correct, I'm not an A&E doctor and I'm working in medicine. So I just thought I've just come off a set of night shifts in a London hospital, and I think the numbers said what Christina discussed is very much what we're seeing on the front line. And in the past few days in my shifts, despite my hospital significantly increasing our intensive care and our critical care capacity, our ITU has been full and we've had no spare CPAP capacity. So, the medics, we're essentially spending our shifts trying to closely monitor all our patients who are on the highest flow oxygen that we can give through a normal mask, essentially trying to assess who is the most unwell and the most unstable, and then frequently checking on the patients that are on CPAP and then trying to see who's showing signs of improving, and then we try and do swaps to swap people off and on the CPAP machines. So it's a very sort of tight situation, and this is not normally, how we do medicine in this country. And our CPAP capacity is not just dependent on the number of machines that you have, but it's also dependent, of course, on the number of staff that you have trained to use CPAP, but it's also dependent on space, because you can't put patients on CPAP anywhere in the hospital because it's an aerosol generating procedure. And our critical care wards and our COVID wards are full. So now our resus department, which is the part of the A&E where you have the most unwell patients, is now become a CPAP ward. So patients who are being admitted who are unwell but don't have COVID now can't be admitted into our resus because we are exposing them to COVID. So that comes to my final concern that, it is winter. So we are seeing, unlike the first wave, we are seeing a lot of people being admitted who don't have COVID. I think about, maybe half of our take is still non-COVID. So it is becoming increasingly difficult to try and keep the non-COVID patients, give them optimum care and make sure that they are protected and safe from getting the virus and keeping patients separate as, COVID cases are just, spilling out everywhere in the hospital. So my question is, I completely support the demands of independent SAGE, but as you said, having a national lockdown now and the rest of your demands, we won't start to see the impact of that in our hospitals for at least a fortnight. So what can be done, right now to alleviate the pressures in hospitals that are becoming overwhelmed? And is there enough variation in critical care capacity across regions and across the country that we can essentially buffer it when hospitals are becoming overwhelmed? So, in my hospital, when we had run out of CPAP, the management did try to put the hospital on divert, to essentially tell ambulances to take patients to another hospital, but we're not able to do that because the hospitals in the neighbouring area were also full. But could we be having a more formalised divert system covering a larger area? So let's say if North London's full, take patients to South London, and of course I know there's a risk of having a longer transfer, but essentially the risk being negated if they're able to get optimum care if they go to an area of the country that is has a bit more free capacity.
Thank you very much for that, Sonia. It's really interesting to have that frontline experience from you, especially when we know that there are people on social media in particular saying it's not that bad, don't worry about it. So hearing direct from clinicians who are there on the front line is really, really important. Thank you for being here today, and thank you for these questions. I wonder if we could invite our guest today, Danielle Bryden, who is Vice Dean of the Faculty of Intensive Care Medicine, for a perspective on a strategy for diverting patients. So Danielle, over to you.
Yes, thank you. One of the things that I think has been worked on considerably over the summer has been the concept of mutual aid, which is the idea that intensive care units and hospitals within regions of the country support each other in terms of moving staff, resource or patients as is needed to areas that have increased demand. And examples of that taking place were around the Northwest in the summer, Liverpool and Manchester. They were able to use mutual aid very effectively. Similar plans exist for obviously all the other areas, but I think one of the things that has been particularly problematic in Wales over Christmas and in the past few days in London is the speed of the rate of rise of admissions presenting to hospital. So mutual aid works when you have got the ability to absorb some of the admissions that are coming to hospital, perhaps look at patients that are coming in for planned procedures and reduce the number of patients that are coming in for planned procedures. But when you get a very rapid rate of rise of patients, it makes it harder to use some of those mutual aid tools. And also, I think it is very relevant, which isn't very often discussed, is the concept of flow, particularly around critical care. So patients that come to critical care might normally stay an average of 5 days in an intensive care bed, but patients coming with COVID are staying longer. They're staying about 12 days on average. So people that come into hospital, it's just not just the numbers that come into hospital, it's the amount of time that they're staying in hospital and needing that additional support. And again, that's when some of those ability to kind of support each other in mutual aid does get impacted. So more than anything, I think in London and Wales, it's been the rate of rise that has caused the pressure.
Thank you very much, Danielle. I'll go first to Anthony. I know you wanted to comment on this.
Just a big thank you to Sonia, and I'm sure you need to go and get some sleep right now. But can I ask you a question? How many of your staff do you think approximately are off sick either with the infection or having to isolate? And is that contributing to a lot of the staff pressures?
I couldn't give you an exact number, but it's a lot. So on my last set of shifts in the medical team, so there's normally 6 of us on the take team, and then 2 doctors. By the last day, 2 doctors were having to, one confirm positive and she got symptoms, and then one had to isolate because he'd been in contact with her. And every day we're getting, messages from the rota coordinator asking people to come in on their rest days and to work extra long shifts because dropping like flies. And the vaccine is starting to be rolled out amongst staff, but I think there's also people are also unclear as to at what point after having the vaccine can we say that staff are immune from getting the virus. So I got the vaccine last week, when I asked saying, what point am I immune? No one could really give me an answer at work.
Thank you very much, Sonia. And Deanan, you'd like to come in on this discussion?
Quickly, Sonia, the Pfizer vaccine protection was started to be seen after about 11 days of the first dose. So if that's helpful. There's a question to Danny, and also in relation to Sonia's comment is about the Nightingale hospitals. So my understanding is some are opened, Harrogate, Exeter, some are on standby, some are being dismantled, such as the Excel Centre in London. I certainly know in London during the previous peak, referrals from hospitals into that Nightingale hospital had to be accompanied by staff moving in the same direction, which was an impediment for many hospitals to sort of carry on that. What is your view of the role of Nightingale hospitals in this, given that you've talked about the mutual aid? Are they worth reconsidering or repurposing maybe for vaccination?
I think from an intensive care point of view, our greatest resource, although there is a lot of emphasis on the beds and the ventilators and the oxygen, our greatest resource is our staff. We need to have trained intensive care nurses, doctors, other professional groups who can look after patients. And that is the limited resource. We went into this pandemic with a low number of intensive care beds, a low number of staff in comparison to many other countries in Europe. So that resource is a precious resource, and it is fragile. So to staff additional intensive care capacity, when you haven't got any increased numbers of intensive care staff, it isn't something that at the moment we as the faculty are focusing on. We're focusing on the intensive care provision in the NHS hospitals and making sure that our staff are appropriately supported, and also individuals who come to work with us are appropriately supported. Other decisions around the NHS Nightingale hospitals and their use are not really consistent with what we're focusing on in the intensive care community.
Thank you very much, Daniel, and thank you so much, Sonia, for your perspective and your question as well. Moving on to our next question now, which comes from the news editor of the BMJ, Zsuzsa Komitovits. Zsuzsa.
Hi.
Hi.
It's Zsuzsa, actually, but that's fine.
Zsuzsa,
it's a difficult name. It's nice to hear you all today. I just wondered if I could ask Danny, push you a little bit further, because you said that the mutual aid system that was operating in the summer in certain parts of the country are now not working. But what will work? You're saying that there are staff shortages. I mean, what would you say to doctors who are in the same situation as Sonia is? That what can managers do to really alleviate the situation? And also, I wanted to ask about universities. You mentioned schools earlier. I just wondered if there was a strategy that you're recommending for university students as well.
Thank you very much. So that first part of the question, Danielle, if you'd like to take that.
Yes. So in relation to mutual aid can consist of a number of things. It can be around using physical equipment, moving it between sites. It can be asking staff to move in separate sites, or it can be moving patients. As part of mutual aid, there can also be a way of looking at the activity that's planned over a region and identifying, if you like, the cases that need to be admitted as a priority over those that perhaps are perhaps able to wait a while. So mutual aid is a very broad generic term, and it is something that has to be managed locally within a region, and almost several times a day reviews taking place in terms of what the demand is and what the activity is. As a clinician myself, you know, it is very difficult when you are working in a hospital environment, wondering, you know, how you're going to address care of patients. But care of patients is the clinical priority for clinicians, and the mutual aid system is something that should be taking place in the background, looking at how resources can be best used. So that's really what I would say at this point, Zsuzsa. I don't know if you have any more specific come back on that.
Thank you very much. So there was a second part to Zsuzsa's question, which was about not just schools, but universities returning. And Susan, you look like you're dying to answer that one.
Yes, we do have a clear plan, and it's on the Independent Sage website about universities. We're calling on all university teaching to be online for the first term, for next term. And many courses already online. The lecturers have spent a huge amount of time putting things online, and the teaching appears to be very successful. We're also calling on students not to return to campuses, if that's possible, to prevent moving around the country in large numbers and further transmitting the virus. But again, this needs to be accompanied by the support from government, especially in terms of ensuring that any accommodation fees are reimbursed to students for next term.
Thank you very much, Susan. Right, I'm going to move on to the next question now, which comes from Linda Geddes, who's writing for The Guardian. Linda.
Hi, thanks for taking my question. 2 questions, actually. The first is regarding schools. So you say that you'd like children eventually to be able to return to school, but you need to make those schools safe. Some schools just don't have extra space. I mean, my children's school, there are no extra buildings where you could accommodate children, and also you need the extra teaching staff if you're going to make them safe. So are we going to end up with a kind of postcode lottery where some kids are able to return to school simply because their school has the buildings available? Or how would you like to see schools made safe when resources are limited? And then secondly, just going back to the vaccine, obviously it's great news that we have that vaccine now, but how would you like to see that rolled out? Do you think we should be getting 1 dose to as many people as possible, as quickly as possible?
Thank you very much, Linda, for that question. Schools is something that we've discussed many, many times, I'm sure you're aware, on our Friday briefings, and talking about the ways that schools can be made safer, and certainly have been in other countries, but with no additional resources in the UK. Susan.
Really good question. We're acutely aware that the many inequalities has become more unequal, partly because of the virus and partly because of government policy. And we have that in mind with all of our thinking. In terms of the extra space, there are many unused buildings that could be repurposed for additional space for schools. There also can be a strategy of appealing to retired teachers and others who can assist with the teaching, especially the online teaching, in much the same way as doctors and nurses who had retired early were brought back into service earlier on in the year. And what we're also saying, this is really important, is to take a partnership approach to this, working with teaching unions, working with parents, working with disadvantaged communities to ensure that no increased exacerbation of inequality happens in the educational sphere, and actually that this begins to be reversed. So thank you very much for the question, really important issue.
Thank you, Susan. And the second part of Linda's question was about vaccines, Deenan.
Yes, just on the question of dosing and or frequency, or the time period between the first and second dose, I don't think anyone is saying 1 dose is sufficient, full stop, but rather the MHRA have said that there can be flexibility of up to 3 months between doses. And they've obviously seen the data and are reassured that still provides sufficient protection. But I think the flexibility means that it may make it easier with the supply chain to actually focus on a large number of individuals being immunized straight off, rather than always keeping vaccine aside for the 1 month booster, if you see what I mean. So I don't think this is actually going to the 1 dose strategy that Tony Blair talked about last week. It's rather just maximizing the potential impact on the population, which I would support based on the MHRA guidance.
Thank you very much for that, Dean, and thank you, Linda, for your questions. Moving on now to Jessica Potter, who is a respiratory consultant in North London. Jessica.
Oh, hi, good afternoon, good morning, sorry. Thank you very much for having me. As Sonia was saying, things are incredibly difficult in hospitals at the moment. I work in acute medicine and respiratory, and we're looking after some of the sickest respiratory patients across our hospital, and our staff are incredibly stretched. We've heard a lot about mutual aid, and I certainly think that's something we've learned a lot from the first wave in terms of decompressing smaller hospitals to help support them to continue to deal with people coming in through the front door who need their care. And so I guess my question is about equity and how we can continue to provide equity of care across the UK for every single patient who needs our help. Certainly my greatest fear as a clinician is having a patient in front of me that I cannot provide life-saving treatment to, that I would have been able to provide like that same treatment to last week. And hearing about the numbers that are increasing, and seeing that on the front line every day. We had one of our largest medical takes. That's the number of people admitted to hospital yesterday, with the vast majority of whom have coronavirus. What do we do when we run out of resource, and who's going to provide that guidance? Because it will harm not only the people who we are unable to treat, but our most valuable resource, as Danny was saying, our staff, because we have a set of values and a code through which we practice, and we're going to have to reduce the level of care that we deliver.
Thank you, Jess, for that question. Danny, would you like to pick that up first?
Yes, okay, thank you. It's an interesting question, and I think one of the things that it's really important to make clear to the public yet again is about the fact that the NHS isn't just a service for COVID. It is about the people that have all the other medical conditions that need to be addressed, and that need also needs to be factored into these considerations of how we're using the NHS and how we're using our resources. Going forward, we have always said as a Faculty of Intensive Care Medicine that our clinicians are to use the normal ethical decision-making processes, and we are very much focused on delivering care to people who need to have that care. And that's why the critical care network system has been in place for many years, which is the concept of linking together critical care beds and making sure that not only people who need a critical care bed get a critical care bed, but if necessary are moved to another hospital where they may get specialist care that they need that isn't offered in the hospital that they're in at the moment. So it is a very complex picture, and despite all the conversation about COVID, it's really important not to forget all the other people that need to have care at this time as well, which is why the public health messaging about transmission of COVID is really important, because it's not just about the individual's risk of getting COVID, it's about the impact they have on other people that may need their NHS treatment as well.
Thank you, Danielle, and thank you, Jess, for that question. I wonder if I could come back to you on that, because you are, facing this horrendous situation where you're anticipating not being able to provide for your patients as you would want to as a doctor. Have you faced that before in this pandemic, or is this as bad as it was back in April, or is it worse?
Back in April, I was working on intensive care as a registrar, and I'm now on the medical wards in a different hospital. I never saw a case where we didn't provide a bed to a patient who needed it on intensive care, and the decisions that were taken as if they were in normal times. And I'm really grateful for that, because it would have not only obviously meant harm to patients, but it would have been significantly harmful to me, and my psychological experience of being a doctor. Things on the front line I hear from, I'm here today speaking on behalf of a network of doctors as part of Every Doctor, an organisation that campaigns for the working rights of doctors. And we hear from people across the country that things are really bad, and that the situation is at the same as in April, if not worse. And with no sign of the numbers going down, we are extremely afraid of what will happen over the coming weeks if we don't act now and decisively. And that's why we're very much in support of Independent SAGE's recommendations.
Thank you very much, Jess, and thank you for all the work that you're doing with your colleagues as well. Moving on to our next question, then, it comes from Tom Magner from Carers World Live. Tom.
Thank you very much indeed, Alice. The official 6.5 million unpaid carers across the UK, now believed to have doubled to around 13.5 million with the pandemic, live under the twin daily threat to their own health and the health of the friend or relative they care for. So on vaccination priority, why are governments telling us at Carers Worldwide that they're sticking to the JCVI age band basis, which tends to leave unpaid carers out in the cold, rather than a needs-based approach, which would put unpaid carers alongside key health and social care workers for earlier vaccination to help save the NHS? Thanks.
Thank you very much. Another question about equity. And Dean, and I wonder if you would like to take that, because it is about vaccination strategy.
I'm sorry, so I lost some of that because of my connection. I lost that full question, Tom. Can you or Alice, in case there's a problem, just rephrase it for me?
Yes, I can. It's basically, officially, governments seem to be sticking to an age band basis for vaccination priority, whereas our audience of unpaid carers are saying, well, shouldn't it be a needs-based approach to put them alongside key health and social care workers?
Well, my comment, it clearly is an essential component of immunization to protect those most at risk. But also to provide confidence to your members and the people that you represent, unpaid and paid, for this. Of course, I think we're as of this morning, we're in a different realm with regard to a much more available vaccine, a vaccine that can be delivered outside of primary of healthcare settings because of the temperature stability. And I would really hope that within the new plan, I'm waiting to hear, we do have Nadeem Zahawi, who is, I'm told, the Minister for COVID vaccine, in order to ensure that there's a clear strategy. I've never heard him talk about vaccines myself. I don't know if anyone else has, but here are clear questions that I think we should be asking for the minister responsible for COVID vaccine strategy to outline, because this is a question over the next 2 weeks, how we get people. So I would very much support your push, as well as, of course, for healthcare workers, which we've not really addressed in meeting, but the same sort of issue is for them. Thank you.
Thanks.
Thank you very much, Dean. And I know, again, this is something that we've discussed, perhaps not this specific question, but certainly the strategy in previous briefings, and the need for transparency around that strategy, rather than the opacity that we seem to have at the moment. Has anybody else got anything to say on equity and vaccines before I move on to the next question? Right, I'm going to move on to the next question then, which comes from Tony Dadd, who is a teacher and a founder of Parents Against Unsafe Schools. Tony Dadd.
Thanks. Actually, I'm a former teacher. I'm now a statistician for 20 years. Thanks for allowing a question on behalf of Parents United Against Unsafe Schools. You can find us on Facebook and Twitter. Thanks also from our community to Sir David for your excellent leadership in times of crisis. Although I doubt there'll be an upgrade to your knighthood in the New Year's Honours list. And to everyone for representing the mainstream scientific community and challenging the dangerous ideas promoted by a minority of scientists out there. Our question on schools is about lateral flow tests. Is the use of self-administered lateral flow tests with poor sensitivity to low viral loads in a school environment like sticking a colourful plaster on an arterial bleed?
Thank you very much for that colourful question, Tony. Susan, would you like to comment on this? We've talked a little bit before about the strategy around testing and what needs to happen in addition to the test itself.
I mean, this is, I think, one for Dean, but what I would say, my understanding is that the point of this is to identify positive cases so that they can be isolated, but they only identify 50%. So just because somebody hasn't had a positive result doesn't mean that they don't have it. And one of the problems of testing, and indeed of vaccination, is the impact on people's behaviour. So the concern is that unless people are given really good information and reminded of that, they may respond to the results they get from it in a way that undermines the whole infection transmission or controlling the infection transmission process. So I think it's really important, but I'm sure Deanan can add to that.
Deanan, would you like to add to that?
Just to say that that, as Susan's, that the one-off testing is not sensitive enough. But one of the roles, I think, in institutions such as schools is that it can be used more regularly. And when used more regularly to capture the time of most infection, I think that will improve the ascertainment and the utility. So I think that those details we remain to be seen, how these tests are going to be rolled out, how the army is going to be involved with this. And this is where the devil is in the detail. I certainly think just a one-off test for all members of the school is not going to be satisfactory for the reasons that Susan has identified.
Thank you very much. There does seem to be a difference in perspective here as well, doesn't there? Because on the one hand, we've got the ability with these rapid tests to pick up outbreaks as they happen. But on the other hand, it's about how robust you feel as an individual and whether as an individual that is actually telling you something useful. Anthony?
Just to say that all the successful countries in control of this pandemic have mobilized communities. And they don't necessarily bring the army in. They bring in a lot of volunteers. Now, you'll recall back in April, we had 750,000 people sign up as volunteers to help out in whatever way they could, and they weren't used. And a lot of those people were retired doctors and nurses. I've had people sending me messages saying, I'm retired, I'm very happy to go back and help with vaccination, help with testing. That's what we've got to do. We've got to devolve power to local communities and have a system whereby volunteers and retired staff and the like can help out, as well as the system of moving clinicians around the country from low intensity to high intensity areas. This is a sort of fundamental principle. And in Wuhan, in China, they moved 9,000 health workers into that capital within 2 weeks. In order to get things under control for 10 million people. We only ever had 270 people to contact trace for 55 million in England. So, you know, we haven't done this mobilization, and it's a fundamental part of any pandemic response.
Thank you very much, Anthony. I hope that's answered your questions, Tony. Thank you for joining us today. The next question comes from Becky Everett, who is a representative from Unison based in Derbyshire. Becky.
Hi, thank you. I am a teaching assistant in a Derby school as well as my substantive role to Unison. For Unison, schools shouldn't open too early while infection rates are so high. While the new strain is taking hold as rapidly as it is, mass testing isn't yet ready for schools, and the vaccine isn't ready to be rolled out across schools for all staff and pupils. So for us, you know, the big thing is our support staff have to work quite closely with children in the tasks that they're asked to do, with the social distance being near on impossible. So what can be done to ensure our schools and everyone who works and learns in them are safe and remain safe?
Thank you very much for that important question. Susan, I wonder if you would like to address that. We've produced a report in the past.
Yes, well, I really earlier went through the plan. I don't know if you were here, of what we're asking government to do. And I'd commend you to look at it. It will be on the website. But I think a really important thing is this idea of a task force, that to make sure that the government worked with the trade unions, with the governing bodies of schools, with local authorities to agree a plan and invests in it. One of the problems throughout this pandemic has been national guidance being set, or nationwide guidance being set, without the resources in terms of financial and practical support for that to be achieved. So for all of the steps of our plan, which includes more staffing, more space, it requires investment. But the point is that short-term investment in this and in the test, trace and isolate system will be well worth it in the long run, because unless we can get the pandemic under control, we won't be able to open up our economy again. So it's a real no-brainer to invest now for the future.
Thank you very much, Susan. I wonder if anybody else has another comment on schools before I move on to our final question. Thank you for that question as well. I'm going to move on now then to the final question, which comes from Karen Hurley, who is a school governor and a mother of 4. Karen.
Yeah. Hi, so thank you for having me. So yeah, I've got 4 boys and we've had to isolate 6 times, mainly back to back now. And it does make me wonder if part of the reason it's spreading so much in schools is there's no financial support for parents at all if they've got to isolate unless they're on benefits. So obviously we haven't had to isolate during lockdowns. We've had lockdown and then had to isolate and then had lockdown and then had to isolate. It's been the worst financial time and there's nothing we can do. It's not like you can go and get a second job. So I do wonder if the lack of financial support for parents is one of the contributing factors of children going into school when they might have a niggling suspicion that they might have a symptom, but they've got a fear of actually seeing that through and getting it tested because they know that it means they might not be able to put food on the table at the end of the week. So I do wonder how much the government has got with this.
Anthony.
Thank you for raising that. We've been banging on about this for the last 6 months. I think it's absolutely fundamental. We've spent more than 22 billion on a test and trace system through lots of contracts with outsourcing and all the rest of it. Yet the fundamental thing that all successful countries have shown is to give proper clinical and financial support to those people that are asked to isolate. They are followed up, they have their bills paid, they have their salaries reimbursed, that kind of thing. We haven't done that. We've offered £500, which is for 2 weeks, which is well below minimum wage. And I was horrified to learn in Liverpool, where they did that mass testing program, that only 4% of people in the poorest areas were actually getting a test. And when they looked into it, it was because none of them were confident they would get the £500 anyway, because 80% of them have been turned down. I mean, this is complete nonsense. And we've been saying this for a very long time. And I'm afraid that the Treasury hasn't responded. It seems that there's masses of money for everything else. But when you want to help poor families to obey the rules on isolation, they're not being helped. And, you know, if people have got to choose between feeding their children and isolating, you know what they'll choose.
And a lot of families are having it back to back as well, which makes it even it's impossible, really. And I've got long COVID. I caught it from my children's school in September. So dealing with the homeschooling, you cannot work when you've got 4 children at home.
Susan, you wanted to comment as well.
Yeah, well, just to say, I mean, if the government can do one thing now that's going to make the biggest difference, it would be learn from what other countries are successfully doing in terms of giving the financial and practical support to people and families having to isolate. In terms of the home schooling, in situations where children are not able to have good online teaching at home, we're calling on those children, joining the children vulnerable, children of key workers, and vulnerable children attending in school. But that would be able to be, because of many fewer pupils, it would be able to be in a much safer condition. But also it requires more staff to be on board to give both a high quality online education, but also give good education within the classroom.
Thank you very much for that last question. And I'm now going to draw this briefing to a close. We have heard about the pressing nature of the evolving situation, the need to make some serious decisions very, very quickly. We've heard from frontline workers in the NHS about the reality of the situation there. And we've heard from families as well and the difficulties that they're facing. I would like to invite Sir David to sum up as usual. Sir David.
I think this has been a very important press briefing. We are at a turning point in this country, and either we turn in the right direction or the wrong direction. And what I want to do, we're appealing, of course, to the government to take action across the board on our 5 key points in our strategy. But we're also appealing to the media, please, to look at the actions not taken by our government over the last 10 months and what that has led to. This really dire situation we're in. And please, could the media do more to put pressure on the government to behave in a proper way? Thank you.
Thank you, Sir David, and thank you very much to all of our questioners and everyone who's been watching, and of course to our panel. All the reports that Independent Sage have prepared to date are available on the website, along with details of the whole team. And you'll also find details of our crowdfunder there. Independent Sage members are all volunteers, and we rely entirely on public support to put on these briefings. Our next regular Friday briefing will be on January the 8th. So I hope to see you then. In the meantime, stay safe, keep well. Thank you, everyone.
Bye.